Hi, thank you everyone. I think I've spoken to a lot of you on the stand out there already today, haven't I? So it's really nice to see all of you again. But yeah, as Sue said, my name's Helen, and I'm one of the lead Immunisation Nurse Specialists in UK Health Security Agency. I think I've lost my slides, but so as Sue said, fabulous, thank you. I'm going to talk about the what, the when, the why and the who of vaccination in pregnancy. So looking at what the UK selective immunisation programmes are for pregnant women, when, so at what point during pregnancy do we vaccinate, why, I'm going to give you an overview of the different diseases against which these vaccines protect, and all of these diseases actually that we'll be talking about have potentially got kind of catastrophic consequences for individuals if they get them in pregnancy. So either for the pregnant woman themselves, for fetal development, or for the baby or the newborn, or potentially for all three. So we'll talk briefly about all of that and why we vaccinate these women. And then finally, if we've got time, we'll look at the who. So who is it that pregnant women trust? Who is it they want to get this information from? And there's probably no surprises from that point of view in terms of where they want to get their information from. So we'll start with the what. So what are we vaccinating against in pregnancy and when? So this is a copy of our complete immunisation schedule, and a lot of you will have seen that on the stand. It goes across the entire life course, so from 8 weeks of age throughout our lives up to and including shingles and RSV vaccination in our 70s and beyond. So it's a really busy schedule. But for pregnant women in particular, they're eligible for 3 vaccines, and they're the ones we're going to talk about now. So flu is the first one, and that one's been around for a little while. So women are eligible for flu vaccine at any stage during the flu season, as soon as they're known to be pregnant. So flu vaccination for pregnant women typically starts in September, and we're aiming to vaccinate as many women as we can, so pretty much every pregnant woman by mid-December, January. And the whole idea is we're trying to vaccinate before flu starts to circulate, but we continue to vaccinate newly pregnant women up to kind of the end of March, so towards the end of flu season. So for women who become pregnant in kind of January, February, early in the year, this would mean that actually they receive 2 vaccines potentially during pregnancy. So one during that current flu season, and then another one in September time as the new flu season starts. The next one we'll talk about is pertussis, or whooping cough for the layperson, and that can be given from 16 weeks of age and should be given in every 16 weeks gestation and should be given in every pregnancy. Operationally, it tends to be around about the 20-week scan because women are naturally coming in at that point anyway. And the final one, which is the newest vaccine that's been introduced to the schedule, is RSV. And this should be given as soon as possible, really, after individuals reach 28 weeks of pregnancy. So the vaccines that we'll be talking about, the vaccines themselves are kind of vary each year for flu. So every year we get an annual flu letter, which includes the list of the different vaccines available for flu in the UK for that season. And for pregnant women, for the last few years, it's been a cell-based inactivated vaccine, which you can see on the left here. For pertussis, we don't have a monovalent vaccine. So what I mean is a vaccine that just protects against pertussis. So we use a combination vaccine. And the main vaccine for use in pregnancy is something called Adacel, which protects against diphtheria, tetanus, and pertussis. So it's a 3-in-1 vaccine. And for RSV, we use a vaccine called Abrysvo. So why do we vaccinate in pregnancy then? So what are the consequences of these diseases for pregnant women and for infants? So before I do that, actually, I just wanted to go through why we vaccinate at all. So the World Health Organization has stated in the past that the 2 public health interventions that have had the greatest impact on the world's health are clean water and vaccines. On our own NHS website, it also states that vaccination is the most important way to protect ourselves and our children from becoming ill. So in the UK, vaccines have helped to eradicate or reduce the spread of diseases, things like smallpox, polio, tetanus. They're now so rare that we kind of very rarely hear about them in the UK, and some of them have gone. And we've also got things like pneumococcal, where the strains now that are circulating are very rare or it's very rare that we see pneumococcal now because of the vaccinations that we use. So vaccines can also save lives. They prevent millions of deaths worldwide each year, and we'll look at some of those stats. And the third reason is by vaccinating, we can protect against future outbreaks. So if people stop getting vaccinated, infectious diseases can spread again quickly. And we've seen that actually in the UK with measles and pertussis over the last few years. So this infographic on the left isn't particularly easy to read, but what it shows is the difference in case rates for a lot of these different infectious diseases the year before the vaccine was introduced, and then on the right-hand side is the number of cases in 2014. So for diphtheria, you can see that we saw almost 51,000 cases in 1941. The vaccine was introduced in 1942, and we just saw one case in 2014. And it's the same for all of them. So if we look at, we've got pertussis, measles, Hib, Mense, for pretty much all of our vaccines, we've seen a massive reduction in cases, not to mention deaths, since we've introduced these vaccinations into our schedule. So vaccination reduces the risk of serious disease, and it saves lives as a result. But what about vaccination in pregnancy? Okay. So the ones that we tend to focus on, we'll come to in a minute, but you'll all know this kind of more than me, but a woman's body goes through incredible changes to support fetal development during pregnancy, and this includes modulation of the immune system. And this is amazing, but the changes to the immune system, as well as the physiological changes that occur during pregnancy, can also present unique risks if an infection is acquired during pregnancy. So these risks, as I mentioned, can be threefold. They can affect the pregnant woman, they can affect fetal development, but they can also affect newborns. So the reason we kind of vaccinate is threefold. It's to directly protect women against diseases that can be more serious in pregnancy, so it's to prevent that maternal morbidity and mortality. And respiratory infections in particular, they increase the risk of maternal mortality, especially later in pregnancy. And risks are also higher for women with additional risk factors such as cardiac disease or diabetes. So vaccines can also protect the unborn babies against the effect of serious diseases in pregnant women, so it can prevent those kind of poor pregnancy and fetal outcomes, so things like miscarriage, premature delivery, low birth weight, stillbirth, and risk of intrauterine death, for example. But finally, the third reason we tend to vaccinate in pregnancy is it can confer immunity to prevent disease during infancy. So vaccinations can also generate antibodies in the pregnant women, which cross the placenta, and these have been shown to passively protect infants against diseases that can be very serious in those first few weeks of life. And we'll talk about that with pertussis in particular in a minute. So let's look at each one in a little bit more detail then. And we'll start with influenza, kind of more commonly known as flu. So flu, we've probably already all heard of it, is an acute respiratory viral illness. It's highly infectious and it can spread rapidly in communities. So even people with mild or individuals that don't have symptoms yet can potentially pass flu on to other individuals. So most flu activity occurs from mid-November, typically peaks in December, but not always, up to kind of December, January, February. And so in 2015, 2016, for example, we actually peaked at Easter. So it does vary each year. But what we want to do when we're vaccinating is we want to vaccinate people ideally by mid-December, because it can take a couple of weeks for immunity to develop. So what we want to do is we want to ensure that individuals have peak protection before flu starts to circulate in kind of January onwards. And we often hear people talking about flu when really they're kind of just talking about a cold or some other mild respiratory illness. So particularly for our kind of lay colleagues, flu is something that's really overused as applied to these milder conditions, and therefore means that a lot of kind of members of the general public think of flu as just a heavy cold. But actually, flu can be really nasty. So while flu is a respiratory illness, which often leaves people kind of feeling lethargic, weak, kind of achy. Has anybody heard of the 50-pound note test? Yeah, so for those of you who haven't, if you see a 50-pound note on the floor and you can't be bothered to pick it up, you've probably got flu, because you can feel that wiped out about it. But yeah, you can feel really kind of generally unwell with flu. But for most of us, actually, often that's it. But flu, the serious consequences of illness from flu is a lot higher in children under 6 months of age, older people, those with underlying health conditions such as kind of respiratory disease, cardiac disease, or immunosuppression. But we see a much higher risk of serious illness in pregnant women as well. And these are groups that are at much greater risk of going on to develop things like bronchitis or pneumonia. So focusing specifically on the physiological changes in pregnancy, these lead to, as you'll know, the kind of decreased lung capacity and tidal volume. It also results in increased oxygen consumption and suppression of T-cell activity. And all of this increases the risk of maternal morbidity if flu is caught, especially if it's later in pregnancy. So we see a higher rate of severe disease, of hospitalisation, of ICU admissions and mortality. And these risks are increased further in women with those additional risk factors such as uncontrolled asthma or diabetes, for example. And it can also lead to those poor pregnancy outcomes such as miscarriage, kind of premature labour or low birth weight. But also for children under the age of 6 months, these are the group that have the highest rate of GP consultations and hospitalisations from flu in the UK. So catching flu in pregnancy, particularly later in pregnancy, can pose a particular risk for newborns as well. So I just wanted to show you this chart, and this kind of talks about the maternal mortality due to sepsis. So the risk of severe disease in pregnant women and the consequences for her and her baby means that routine flu vaccination was introduced for all pregnant women into the UK schedule in 2010. So since then, rates of maternal death from flu have dropped, but we do still see cases each year, and we've actually seen 1 to 2 cases in pregnant women per 100,000 in the UK every year since 2016. So you can see on this green line, this is taken from an Embrace report in 2023, but you can see that the green lines decreased as a result of flu vaccinations, but we're still seeing cases year on year. So there's a huge amount of research, and one of the things we often get asked, particularly in pregnancy, is are vaccines safe? There's a huge amount of information out there, and it can be really difficult for pregnant women to navigate their way through all of this. It can be difficult for us to navigate our way through all of this. So there's been a lot of research, and study on study kind of consistently shows that vaccinations in pregnancy are effective, the benefits for the pregnant woman, for the unborn child and the neonate, but also that they're safe. So there was a large study by Peabody et al. In 2010 that showed that pregnant women should be offered the inactivated flu vaccine because the risk of serious illness from flu is much higher in pregnant women. In addition, there's been a number of studies that show that flu vaccination during pregnancy provides that passive immunity against flu to infants in those first few months of life when they're particularly susceptible. And another study here by Omar et al. In 2011 showed that flu vaccination reduced the likelihood of prematurity and smaller infant size at birth associated with flu infection. So they're effective, but are they safe? And this is what a lot of our women want to know. So a study by Tamar et al., which isn't on there actually, but she conducted a review of studies on the safety of flu vaccines in pregnancy and concluded that the inactivated flu vaccine, so the one that we offer women, can be safely and effectively administered during any trimester in pregnancy, and that no study to date has demonstrated an increased risk of either maternal complications or adverse fetal outcomes associated with the flu vaccine. The data is a little bit more limited for the live vaccine, but that's the one that we give to children, so we don't tend to give it to adults. But actually, having said that, there's no evidence of risk of that live vaccine, even if it has been inadvertently given in pregnancy. So there have been lots of studies into the safety of flu vaccines in pregnancy. There's also been extensive use of it. So 11.8 million pregnant women received the vaccine in the States between 1990 and 2009. So we had loads of evidence before we even started using it in the UK. And a follow-up of more than 2,000 women and their babies up to the age of 7 years of age, so it was a long study, showed no increase in stillbirths, in congenital malformations, in malignancies or neurocognitive disabilities. And a combined follow-up of over 4,500 women showed that there were no significant adverse effects identified at all. So flu is really nasty. It can have particular consequences if contracted, particularly later in pregnancy. And we've got lots of evidence to show that the vaccines are effective and safe. But they're only effective and they're only safe if they're actually administered. So how high is the uptake in the UK? So this particular chart shows annual flu vaccine update for pregnancy in the UK. And the end of year season data isn't available for this year, obviously, because we're not at the end of the year yet. But looking at our uptake so far is broadly consistent with kind of 22-23, so last year. So as of the 25th of January this year, uptake in pregnant women was 33%. And it's plateaued since then. So that's kind of broadly consistent. But what you can see from this is that uptake in pregnant women has been decreasing for the last 6 years. We do need to be a little bit cautious when looking at the absolute numbers because there is some difficulty in terms of extrapolating this data, and the way they've extrapolated it has changed over the past few years. But what we are seeing is a general decrease. So let's look at pertussis then. So pertussis is an exclusively human pathogen that affects people of all ages, but it's infants and young children that have the highest rate of complications, and almost all of our pertussis deaths occur in infants under the age of 1 year, particularly during those first 3 months. And often it's adults and older children who are out in the community, going to nursery and different things, bringing it home, that are exposing these younger siblings to it. It's a really infectious disease. The bacteria tend to sit really nicely in the back of our throat, and it's spread through kind of coughing and sneezing. So it's also known as whooping cough, and if ever you've heard a young child with it, there's a really distinctive kind of inspiratory whoop that you can hear when they've got pertussis. And it tends to be cyclical in nature, so we tend to see a peak kind of every 2 or 3 years, and that's quite natural in the way that we tend to see pertussis cases. So in adults, pertussis rarely has any significant consequences or serious consequences. I had it in my 30s, and other than kind of aching a lot and not sleeping particularly well because I was coughing all night, there wasn't really anything. My colleagues didn't particularly like sitting next to me. There was kind of nothing really else that was significant for me at that point. It can cause coughing to the point of vomiting. It can lead to nosebleeds. It can lead to conjunctival hemorrhages and bruised and sore ribs. Very occasionally it causes a hernia as well, but usually there's nothing more than that. We've got that respiratory reserve to be able to cope with pertussis, but it's a very, very different story for our infants. So in terms of infant morbidity, pertussis in infants can result in severe complications such as excessive vomiting leading to weight loss, pneumonia, episodic apnea, seizures from hypoxia because they're so busy coughing they can't actually breathe, encephalitis. There can be longer-term consequences such as brain damage. It just goes on. And 90% of infants who contract pertussis will end up in hospital. In terms of infant mortality, typically in a peak year, we tend to see about 5 to 8 deaths from pertussis in the UK in a standard year. We've had a particularly bad year in 2012, which is when we introduced the programme, and again last year. So infants, like I've said, are at a particular risk of mortality from pertussis. So we start our vaccination programme at 8 weeks of age, once an infant's immune system is mature enough to be able to respond to vaccines. So how does that affect our pertussis rates? So this graph looks at the number of confirmed pertussis cases in England from 2012, or in 2012, by the first year of life. And if we look at the onset of pertussis by age, what we can clearly see is prior to introduction of the maternal programme, most cases in England were in those who were too young to be immunised themselves. So you can see this grey box on the grey charts on the left-hand side. So all infants need to receive 3 doses of the vaccine, so 8, 12 and 16 weeks of age. So they need to receive it in a timely manner in order to gain that maximum benefit from the infant programme. And cases in fully immunised infants, as you can see to the right, are really rare once they've had all 3 vaccines. So what we needed to do is we needed to protect those children on the left-hand side. So in 2012, we saw a peak in cases. And in response to this, a decision was made by the Department of Health to recommend pregnant women receive pertussis-containing vaccines for neonatal protection. So pregnant women should now be advised to have their pertussis-containing vaccine from 16 weeks of age. But like I said, ideally, we generally tend to give it around 20 weeks when they're in for their fetal anomaly scan. And ideally, we want to give it before 32 weeks of age so that mum has generated that protection and it's had that transplacental crossover and is now protecting baby. So vaccination against pertussis for pregnant women is the most effective way of providing protection to infants during those first 2 months of life or 8 weeks of age when they're too young to have the vaccinations themselves. So just quickly then, looking at the impact of the vaccinations in pregnancy, a vast majority of cases in infants aged 5 months are still in infants aged 5 months and younger. But until 2024, we've definitely seen less cases than we did in 2012. And you can see kind of a general overall decline here. I just wanted to point out the scales, because actually if you look at the hashed line, so the black dotted line and the orange one at the bottom, that's in our infants under 3 months of age and 3 to 5 months of age. If you look at the scales on this, what you can see is that actually the scale for those under the age of 5 months is 10-fold higher than it is for children 5 months and over. So actually if these were all on the same scale, those children up to the age of 5 months would be off the top of this chart. So we still, a vast majority of our cases are in our infants under the age of 5 months and younger. What you can see from this is that COVID has impacted on circulation. We had that nice plateau in 21, 22, and then we started to see an increase, and we had a significant increase in 2024. So this is our cases kind of from 2018 through until 2024. You can see the lines are the years between 2018 and 2023, and then the bars are showing the cases per month in 2024. So you can see that we peaked in May of last year at over 3,000 cases, and that's compared to kind of in the 6 years prior to that, we were seeing less than 500 cases a month. So it's sixfold higher May last year than usual. And bearing in mind that most of these cases occur in infants, and this is the group that are at risk of seeing severe consequences, it's no surprise that actually we saw more deaths than usual last year as well. So this graph shows infant mortality from pertussis between 2001 and November 2024. And in the 12 years prior to the maternal pertussis programme, we saw 63 deaths in babies aged under the age of 1 year. Since the introduction of the programme, we've seen 31 deaths in babies with confirmed pertussis, and all of these were in babies who were too young to be vaccinated themselves. And of these 31, 10 of them occurred last year. So, and of those, so of the 31 in total, 25 had mums who were not vaccinated in pregnancy, and of the remaining 6, most of them were very late in pregnancy, so full immunity may not have been acquired by that point anyway. So again, we can see from this that vaccination in pregnancy is effective at protecting our infants, and they're the ones that are at that risk of severe consequences from pertussis. But again, what are our uptake rates? So, like flu, pertussis uptake has been dropping. So in 2017, coverage was around 70 to 75%, but this dropped down to 58% in 23-24, and it was even lower in some areas of London. We were talking about 24% in some areas, so it's really low. So the black blotted line that you can see here shows that is up to September 24, and you can see that we've actually seen an increase in coverage, which is amazing news. We need to be a little bit cautious because, again, we've changed the way that we're recording, but this still looks really promising, although it's still lower than we'd like it to be. So again, how effective is the vaccine? So studies consistently demonstrate that the vaccine's safe in pregnancy, and there are lots of studies out there. So we've had one by one of my colleagues, and I can never pronounce her surname, so bear with me. It's Amithralingam, so Gayatri Amithralingam. She conducted a review of the effectiveness of the maternal programme with her colleagues, and they looked at 3 years' worth of information, so 2012 when the vaccine was introduced through to 2015. And this highlighted actually that the maternal vaccination is the only way of certainly protecting vulnerable infants from that significant risk of illness and death during those first couple of months. So Laverty et al. Looked specifically at the safety of the vaccines, and this study followed up children for 6 years, and they found that there was no significant risk of adverse childhood outcomes, and in contrast, actually, it actually looked as though it has some sort of protective effect in terms of protecting against upper respiratory infections, gastrointestinal infections, etc. And then the MHRA, who monitor all of our medicines, closely monitor our vaccines as well. And pertussis vaccination has been extensively monitored by them. And Donegan et al. Looked at this as part of the in support of the MHRA, looked at over 20,000 women vaccinated in pregnancy and found that there was no evidence of an increased risk of any of the kind of extensive predefined list of adverse events related to pregnancy. So there was loads out there. And this, again, is a study by Helen Campbell et al., which looked at a large systematic review, looked at over 16 studies from across several countries, which covered over 150,000 women who had been vaccinated in pregnancy, and concluded that the pertussis-containing vaccines used in pregnancy have reassuring safety profiles for both pregnant mum and for baby, pregnant woman and for baby. I'm conscious of time, so just there were a couple of other studies called IMAP studies. So this stands for Immunising Mothers Against Pertussis. And these studies were reviewed by the JCVI, who are our expert committee who advised the Department of Health. And actually, these studies did lead to a change in vaccines. So what these studies found was that what used to happen was mums would be vaccinated against diphtheria, tetanus, pertussis, and polio. So 4 different antigens in pregnancy. What we found with that is then actually when the infant is born and the infant is vaccinated, actually their response to polio is a little bit lower than those who had never been exposed to polio antigen in pregnancy. So the protective threshold was here. They're still well above that protective threshold, so they're safe vaccines, they're effective vaccines, and they work, but it was just a little bit lower than those that hadn't been vaccinated. So what came from that was, as we've got a vaccine that's available that doesn't contain polio, the advice was to switch to the tetanus, diphtheria, and pertussis vaccine or Adacel, and that happened in summer last year. So the vaccine we had was good, it's just that we had an even better one that had come on the market, so we switched to that one, which is good news. So finally then, this is the one I can never pronounce, respiratory syncytial virus, or RSV. So this is the newest one that's come into the programme. So RSV is a viral infection, it's highly communicable, and humans are the only known reservoir. Lots of people that we've spoken to today, and we kind of speak to regularly, say, I'd never heard of RSV before the programme came out. And actually, unless you're a paediatric nurse working in neonatal intensive care or used to kind of dealing with bronchi babies in their first year of life, you probably never would have heard of RSV. But actually, it's a really common virus, much more common in the winter. And over 60% of children will have been infected by their first birthday and 80% by 2 years of age. For many of us, though, especially kind of younger adults and older children, usually just results in those kind of general wintry, kind of grotty, coldy type feelings and symptoms, but not much more than that. Again, very different for infants. So for infants and for older adults, the risk of acute kind of lower respiratory tract infection, and for our infants, associated bronchiolitis is much greater. So short or longer term complications such as apnea, hypoxemia, kind of cardiovascular abnormalities and bacterial infections, including pneumonia, are also significant. There's also, if children have had RSV bronchiolitis, they may well be at increased risk of developing asthma later in childhood. Now, we don't quite know enough about that yet, so we don't know whether or not it's that they're more susceptible to both, or whether or not this RSV bronchiolitis is leading to a higher risk of wheezing, of current wheezing later. But actually, if we vaccinate against RSV and we see a drop, we'll probably learn a lot more about that. But also, RSV is actually the leading cause, or a leading cause, of infant mortality globally, which, bearing in mind we didn't know much about it as healthcare professionals, still blows my mind a little bit. But also, it results in 20 to 30 deaths in infants per year in the UK. And it's those that are most at risk of severe and occasionally fatal RSV infection, like I say, those young infants who are born, particularly those that are born prematurely, or those that have predisposing conditions such as chronic lung disease, congenital heart disease, or children that are immunodeficient. So again, like the other two, RSV can be nasty. So the RSV vaccination programme commenced in September last year. It's a single dose of a vaccine called Abrysvo, and it's given as soon as possible after a woman reaches 28 weeks of pregnancy. So many of the antibodies produced by pregnant women at this stage in their pregnancy are then transferred across the placenta and protect baby during those first few months of life when they're at greatest risk of complications. I think it's probably important to highlight here that there's a separate monoclonal antibody program given to high-risk infants, but that's not this vaccine. That's a totally separate program. So Abrysvo isn't licensed to be given to high-risk infants or to any infants. So although it's a new program, it was only licensed in the UK last year. It's been extensively studied, and it's also been used in other countries like the US. And studies have shown that the vaccine is effective when given in pregnancy, showing it can protect against severe lower respiratory tract infection caused by RSV, and the studies show that it protects for at least the first 3 months of life. And that's the time when babies are most at risk. So by vaccinating mum, we protect during that risk period for those first 3 months. So in terms of safety, it's been trialled in over 17,000 adults over the age of 60 and over 4,000 women. And as of July 24, which was just before we introduced the programme in the UK, it had also been given to more than 100,000 pregnant women in the US, where monitoring showed that it had a good safety record. So we were very confident when we rolled it out in the UK. In terms of side effects, they were the general side effects we tend to see, so a bit of a headache, injection site pain and myalgia, all the types of things we'd usually tend to see, and they were the ones that were most frequently reported when given to women in clinical trials. There was a small safety, and when I say small, as in it was a small safety signal, in that we didn't think it wasn't statistically significant, so we didn't think it was anything, but continued to monitor, in terms of premature birth. So in the vaccine group, there was an ever so slightly higher rate of premature births than in the unvaccinated group. So it was 2.1% as opposed to 1.9%. That was really closely monitored, and as we've kind of continued to monitor that safety signal, there's nothing to suggest there are any problems with that at all. It was a spurious result during the study. So we're kind of very reassured that it is it's a good vaccine, it's a safe vaccine, and there are no concerns really in terms of any serious safety or signals for when given in pregnancy. Now, I'm really conscious of time, so I'm going to flip through this last bit, which is who do parents trust in terms of vaccinations. So we, in the UK Health Security Agency, we do annual attitudinal surveys where we'll survey a whole range of different people. We'll ask them what they think about vaccinations, how they found their vaccination experiences previously, and just kind of a lot of kind of general things about their views on vaccination. And really what we consistently find is that health professionals, so like you and I, are consistently rated in that first kind of 1 to 3 as in terms of the most trusted sources of information. And that's always us alongside kind of general NHS, or NHS generally, so like our websites and things, and pharmacists. Don't ask me why pharmacists are in a separate group, but pharmacists. So we're definitely trusted in terms of information. In terms of who pregnant women were saying they were having their discussions with, or kind of new parents, the people they remembered were the health visitors and you as the midwives. So actually the conversations that you're having as well, and a lot of people say often, I don't feel particularly confident, but actually just having that initial kind of basic information and being able to have those conversations can make a big difference for pregnant women and families, because you're the ones that they remember. And then in terms of, finally, who do pregnant women want to get their information from? Again, this is no surprise that they trust you as their midwives. And so the information that you can give, and we find this time and time again. So this study was done in 2015. There have been loads since. I've just put this one up because this was the nicest graft. But actually, they all show the same thing, is that pregnant women love you, and the information that you give them is really reassuring. So please do keep doing what you're doing. So just then, very quickly, in terms of a summary, pregnant women are at a unique risk of infection as their immune system modulates to support fetal development. Vaccine-preventable diseases can be nasty. We've got vaccines available that are safe and effective for flu, pertussis, and RSV, but please do keep having those conversations, because what you're doing really does make a difference. And I'll stop there. Okay. Thank you.